Good afternoon, everyone. This is Andy Reese with Department on Disability Services. As usual, I'll start today by sharing our data. So unfortunately, we are now up to 439 people supported by DDA who have contracted COVID-19. There have been 5 thus far in September. By placement type, these break down as follows. There have been 9 in host home, 114 in ICFs, 1 in a mental health facility, 58 in natural homes, 2 in a nursing home, 4 in out-of-state placement, 40 in residential habilitation, and 211 in supported living. And just for people that are tracking this, of the 5 people who contracted COVID in September, 3 were vaccinated, 2 not vaccinated. The 2 not vaccinated both live in a natural home. So this represents in ICFs of the 114 people who have contracted COVID, that represents about 38% of the people in intermediate care facilities. Of those 114 people, we have had 13 confirmed COVID-related deaths. There have been a total of 28 of those 114 have died, but only 13 are confirmed as COVID deaths, representing 11.4% of people in ICFs who contracted COVID who have a confirmed death from COVID. In natural homes, the 58 represent about just a little over 6% of people in natural homes who have contracted COVID. Just for some context for people, generally in the city, it's at about 7%. So that's a good thing. Of those people, of those 58 people, we have had 5 deaths. All are confirmed as COVID deaths. Represents about 9% of people in natural homes who've had COVID who have then died from COVID. The 40 people in residential habilitation placements represent about 36% of people in residential habilitation. 3 of those have died. Only 2 are confirmed as COVID deaths, so that those 2 represent, I did the math incorrectly. I'll have to fix that. It says 7.5%, but that's incorrect. When I post this, I'll correct it. I'm not going to try and pull up my calculator and correct it right now. Supported living, 211 people in supported living have contracted COVID, representing approximately 23% of people in supported living. And of those, we have had 15 confirmed COVID-related deaths. 22 people in supported living who had COVID have died. So confirmed deaths from COVID represent about 7% for people in supported living. Overall, in DDA, the 439 people represent about 18% of people supported by DDA. Of those, we've had 37 confirmed COVID deaths that represent about 8.5% of the people in supported by DDA who've contracted COVID and have confirmed COVID deaths. So by placement type, in September, we've had 2 people in natural homes, 2 people in supported living, and 1 in residential habilitation. Of the people who've contracted COVID, We have not had anyone, fortunately, who has required hospitalization since April, and at this time, no one currently in the hospital who has related to COVID, of course. So there have been 61 people who've contracted COVID who've gone on to die. Given the length of time that's passed, there certainly are a number of people for whom COVID was not the cause of death. So of the 61 people who've had COVID, 16 have been confirmed as non-COVID deaths. And for 8, we are still awaiting the final cause of death from the medical examiner's office. So the total number of confirmed COVID deaths that we have is 37, and there have been none since March. Among provider staff, 720 provider staff have tested positive for COVID-19. 52 of these staff have been reported by more than one provider agency, and we have had 10 provider staff deaths from COVID. Vaccination rates. Amongst the people we support, we didn't really see much movement this week. So the total, it says updated 9/2. That's not accurate. The updated report that I got yesterday, though, does still reflect 77% of people supported by DDA. In host homes, 78% of people in host homes have been at least partially vaccinated. 98% of people in ICFs, 61% in natural homes, 96% in residential habilitation, and 85% in supported living. Provider staff, we have an update as of yesterday. It's at 68% of staff who are fully vaccinated. And amongst DDS staff, the report that we have from a week ago from the city administrator's office is that 84% of our staff have been fully vaccinated for COVID-19. So DDS staff by September 19th will need to either be fully vaccinated or have an exemption or test weekly. And for provider staff, they have until September 30th to either be vaccinated or have one of 3 exemptions, but there is not the option for provider staff of testing instead of the vaccination.
Hello, please leave a message after.
So there's a question here for clarification regarding DC health guidance updated September 8th, which requires 14 days quarantine for people in a healthcare facility, including supported living, who've had close contact with a confirmed COVID-19 case. In addition, the guidance states people in supported living may not waive the 14-day quarantine requirement. And I believe we have Nelson with us here today from DC Health.
Sorry, which document specifically are they referring to? I actually wasn't aware that guidance had posted yet.
I wasn't either, because I looked yesterday and didn't see anything, but they say guidance that posted on September 8th, and yesterday was the 9th. Oh, quarantine after COVID-19 exposure, September 8, 2021.
So I'm pulling up that guidance now. If you'll just give me a minute, maybe we can come back to that question. To the best of my knowledge, none of those recommendations are changes. So let me just pull that up and I'll answer that shortly.
Thank you. So I'm going to move on because I do now see what they're referring to. It's at the bottom of page 2. And then as soon as you can respond, Nelson, just feel free to jump back in. So the next question is part of, oh, you ready?
Yeah, sure. So this is actually, there's nothing that's changed from the previously posted guidance. So this is what was posted before, but how it's stated is correct, that quarantine in healthcare facilities, I see how it does say healthcare facility and congregate staff, but these are high-risk settings, and so the recommendations are still to adhere to 14 days of quarantine, which means that the exceptions for the community to reduce quarantine to 10 days, for example, are not recommended in those settings.
So as part of the approved ARPA, and in light of the short time between now and September 30th, has an amount been determined yet as to the vaccination reimbursement incentive for IDD staff? Please update the status of that initiative as the way to incentivize staff to get vaccinated. I don't know if Chanel is here. I'm pretty sure that that was referenced in our plan specifically. And the plan does not call for an incentive that is paid to each individual. It allows much more flexibility than that for there to be an incentive paid to a provider based on the number of employees they have with a per employee amount that's paid. I don't know if Chanel is here, who's more familiar with the specifics of our plan, but I'm pretty sure that the amount was in the plan. So I don't want to speak off the top of my head, but if someone can take a look at the plan and relay that information. And it was, as I say, it is intended to be a very flexible payment, which is a reimbursement for incentives paid to staff, to allow provider agencies like ones that we have had who have done who have tried different kinds of incentives in order to improve their vaccination rate among staff. And so there was a dollar amount per staff person. How does the information regarding possible or probable COVID death certificate affect DDA statistics? I don't understand that question, except that if the cause of death on a death certificate is COVID, then we would indicate that it was COVID. In the instances where we have said it is not COVID, it is because COVID is not referenced as the cause of death, as a contributing factor in the death. It's not on the death certificate on those 16.
Director Reese, if we could just jump in real quick. So for the ARPA plan, we did not specify the exact amount or reimbursement type for the vaccination incentive reimbursement. However, I will say this is a district-wide proposal, and so we're waiting on DHCF to come up with a plan. We will circle back with our colleagues at DHCF to make sure that we can get as much information out as possible as soon as possible. I will say, though, I don't think we are on a 9/30 end of fiscal year deadline for this. I think this may happen after the current fiscal year. But I will circle back with more information for the coalition and for others as well.
There's a statement, it's critical to get the incentive plan done by September 30th, as it can encourage staff to stay in their position. This needs to be a priority. It is a priority. Please do keep in mind that we got approval like 2 weeks ago, and the ability to pay the funds is not going to happen in this fiscal year, but that doesn't mean that we won't be able to let people know the specifics of the amounts that will be paid. Do we have responses from DC Health from all of last week's questions? I know that Charlene Wills is here with us today.
Hi, Director Reese. Yes, I do. I will be sending it to you formally, probably by close of business day. I'm sorry for the delay. I had hoped to send it to you a little earlier in the week, but I do have my responses, and I will be submitting it to you by close of business today, if not earlier.
Okay, so thank you. As soon as we get that, we'll send that out to folks. Does DC Health still expect individual providers to develop their own exemption forms? It's hard to see how those can be developed and reviewed by DC Health in a timely way, given the September 30th deadline. I can't answer the first part. I can say that the second part was one of the written questions, which was, if you submit a request for a waiver, are you okay from the date that is submitted to go ahead and keep working until you get the approval from DC Health? In the same way, if you're a licensed professional, if you submit your application to renew your license, it'll show up on the DC Health website as pending, and you are okay to practice as long as it is pending or active. And then I'll let, if Ms. Wills has anything to add in addition to that.
I agree with that, Director Reese. However, I would add, but it requires you to submit the exemption before the 9/30 deadline. If you submit it after the 9/30 deadline, it wouldn't be deemed as promptly submitted, and it could be deemed as a non-compliance because you did not. There were certain things you have to do by the 9/30 deadline, and that includes fulfilling if you're going to submit an exemption. So submitting an exemption after 9/30, you may be found in violation of the regulations. I just wanted to clarify that point, but I would agree with you, Director.
And I believe all the providers received communication from DC Health this week regarding the portal that is available for people to submit this information.
I do believe that is correct, and if you would like me to confirm with Dr. Lewis's division, I would in my response this afternoon.
I mean, I saw a letter that went to one of the providers, and I know they had the email addresses for all providers. And yes, the letter, there's a question here. It says portal, including non-licensed staff. That is what the letter says. There's a question, is there a link for that communication? There are providers that do not know about it. Certainly, I don't know if you've received it, Ian. I can send that letter to you, but we can also make sure that non-coalition providers receive it as well. But I'll forward the letter that I received to you. Where is the portal located? How are unlicensed employees entered? So if in the letter, it has a link to the portal. And so you just follow that link and follow the instructions. So we will go ahead. I will forward it to Kirk and Ian, and we will go ahead and forward the letter again today to all providers, because I'm seeing a number of people saying they've not received it. But I know that we provided our email list to DC Health, And I know that someone from that list contacted me and showed me the letter. So, but at any rate, we will send that out again after this meeting. CTC goes live on 10/1. Maybe you could say what CTC is. I'm trying to figure that out. Can you talk about what, contribution to cost? Thank you. Contribution to cost of supports goes live 10/1. Can you talk about what DDS is doing to prepare for the calculation that will need to be entered and the process for determining relative funding between the individual and DDS? We will be, there's a provider leadership meeting on is it the 23rd? And there are meetings with all service coordinators. The policy goes live October 1, but I don't think that anybody actually, and maybe Crystal could jump in if I'm incorrect here, I don't think anybody is affected for at least 6 months after that. It's like their first ISP meeting after it goes into effect. But anyway, if Crystal, if you could talk about the timing of the implementation of that. So we are addressing it with people this month. It is one that we've talked about quite a bit, although not for a little while in public forums.
Correct. It's 6 months after the individual's ISP. But the policy itself is effective 10/1.
So to the extent someone was going to have an obligation, it would be discussed at their ISP meeting and would go into effect 6 months later. Is that what you're saying?
Correct. It's effective 6 months after the individual's ISP start date. But again, as you mentioned, we will talk more about that at the provider leadership meeting. And from my understanding, there are meetings being held with different units within DDS.
What is DDS doing to support persons' resume day program participation? Holistic day active treatment has opened, and most support teams are declining their person to attend day services, even though we have thorough COVID-19 strategies. This is a really good question, and I will say we're discussing this right now at DDS and very concerned about the same issue that you're raising here, which is, and it's also related to the issue that, or the conversations that we have had with people we support, DSPs, our staff, around the rights of people we support, and ensuring that their role in these IDT meetings is respected, so that when you have a person who wants to go back, you don't have a team sort of overruling that person. And there is a lot to consider here, and we'll actually be talking about this more also at our provider leadership. The effects of social isolation are also significant. And so what we really need to begin looking at, as we sort of evolve from one stage of COVID to the next, all of us have been having to learn, how do we live in the community safely? And I think this is also something that we have to be teaching or helping the people that we support to learn. There are negative effects of staying at home. Keeping in mind as well that the recent Appendix K also allowed for the ability, at least in the waiver, for the ability to be providing remote day while also paying for companion, so that all of us now, whether we've been vaccinated or not, when we go out, if we're going to be indoors with other people, need to have a mask on. And so as teams talk about a person going today, that would certainly be a significant issue they'd be discussing, is the person's ability to take the mitigation steps they need to take to ensure their own health and safety. At the same time, the teams really do need to be having this discussion and thinking about the whole person when they're doing it. And, coming up with safe ways for people to engage in activities outside the home. I've talked since the beginning of this, even when we were in a total shutdown, about the importance of getting outside and exercising. of being active. But there's also the importance of engaging in the community. I've heard anecdotally from folks who have been able to return to day services about how positive the ability to see people who they know from their day program, you know, socially, emotionally, psychologically, how important that is to them. And so, and how important it is to be engaging in the community and not stuck at home. And so we will be talking about this more on the 23rd because I do get concerned that perhaps out of an abundance of caution and concern for people's health, that teams are pushing back a little against a person's desire to re-engage. And I mean, I can just say, after spending not that long inside my house, I couldn't keep doing it. And so, for the people we support, it really, and I'll also say, as we submitted our most recent Appendix K amendment, CMS was pushing back and asking questions about what are you doing to ensure that people are not experiencing social isolation. And so we are going to be looking at some specific questions that need to be asked at these team meetings about, sort of specific health issues that may exist that would warrant a person, not engaging in a program that would be indoors where they're not able to mask, or figuring out ways that the person could engage in the community and providing appropriate services to do so. And so we will definitely, at our provider leadership, we'll talk more about that. And then following that, we can talk more about that here. Do providers begin collecting the contribution to costs on October 1 for people for whom DDS is not the rep payee? No, that doesn't change. This is, I don't believe that's in our policy at any rate. And Crystal, you could correct me if I'm wrong, but I don't believe that's in the policy. What if it's already worked out that those funds are coming to DDS, they still come to DDS. The issue is for some folks where our payment to the provider will be reduced because of the funds that we receive. And how is that made up? In those instances, the person pays it over to the provider agency. And as Crystal said, it's discussed at the ISP meeting and then implemented 6 months later. So for any person supported, just recognize that there's a very long process before we get to the point of making any changes that will directly affect their lives in terms of a change in how their contribution is done. Someone provided a notice that the Community Service Advisory Council is hosting a town hall meeting for the community to address violence impacting the community. The meeting will be held September 16th from 6 to 7:30 via Zoom. If you could type in information about how people would get access to that Zoom link. The next question, will family members ever allow the person and their family to return to day services since the families are being paid to provide services at home? I believe it's highly unlikely. in many instances, they are likely being paid as a companion during the day. And just as a reminder to people, the Appendix K flexibilities allow us the flexibility. They don't require us to do things in a particular way. And so as we move forward, and it appears that the that providing the service in that way doesn't continue to be either necessary or in the best interest of people that we support, then we can make shifts to that without having to amend the Appendix K. The Appendix K allows us to do things in a particular way, doesn't necessarily require it. And so, you know, this issue that's being raised has been raised. I've heard it about families, I've heard it about residential providers planning for the support. You know, residential providers figured out how to do it. And so it has been a challenge. So now that they've figured that out, having to shift in this way, it, you know, may be a challenge. But like I say, we will talk with at our provider leadership meeting. We'll be talking about this, and more to come on that. I think that from my perspective, kind of the most important takeaway there is a couple of things. Primarily, this concern about social isolation of the people that we support and ensuring that they can engage. Because in terms of health and safety, there may well be people who have to be very cautious about going into the community. But that means that the team and the person have to be creative about how to bring the community into them. Because we do want to make sure that people are engaged. We also want to make sure that when this thing ends, that we have day providers. And so, you know, we have to figure out ways. We've made the recent amendment to the Appendix K, but we have to come up with other ways that we can ensure that our day providers are able to provide services, because otherwise when we need them to provide services, they won't still be there. But as I say, my primary concern is the people we support. And then figuring out how we maintain a stable provider community to support people during the day, because you know, this plan regarding providing companion services in the home was not intended to still be in place a year and a half later. You know, people who worked with us on coming up with the community, the assessments that are done, returning to day, will remember that it's been a year since we developed that, anticipating, you know, that we were near the end and people were going back today. And so we really need to talk more about what people are doing during the day and how we get people fully engaged during the day. So someone is saying that the rulemaking allows providers to require regular testing for non-vaccinated employees, but I heard at the beginning that this is not an option. What the rulemaking allows is that a provider can require weekly testing for employees who have a waiver, and waivers can be allowed in 3 circumstances. One is that the person has a health reason for which they are unable to get vaccinated. Second, a sincerely held religious belief that prevents them from being vaccinated. Or third, they have received a vaccination outside the country that's not one of the 3 vaccinations that's required by the regulation. in those circumstances where the vaccination is waived, there is not a requirement for weekly testing. But what the rule says is that the provider may require weekly testing in those circumstances. And for people that heard the press conference on the day that Dr. Nesbitt discussed this, at that time, there wasn't yet full approval for the Pfizer vaccine. And she said at that time that once full approval comes, the option of testing versus a vaccine will not be available, because it was only available because it was a provision of the emergency use authorization.
And Director Reese, I want to add that the third provision, Charlene Wills again, being exempted because you had a vaccination out of this country that wasn't Pfizer or Moderna or the Johnson & Johnson one specified in the regulation, what the regulation language has, and this is what I drafted in our response, is it has to be one that was recognized by the World Health Organization.
Thank you. Thank you. How are you monitoring the ISP data collection for people you support while they're not in day services programs? Are they adequately trained to collect the data? And let me just see if I'm trying to see if we have a service coordination person who is not muted and able to speak. And they can respond to that. I do know that they are monitoring for a person's goals, and so they would be looking at whether those goals are being addressed regardless of how they're supported during the day. But I'm hoping that someone who can answer your question more specifically is here.
Director Reese, I've unmuted Shasta, our service coordinator manager.
I'm sorry, could you repeat that question? I don't see it in the chat.
Yes.
Thank you.
How are you monitoring the ISP data collection for people that you support while they are not in day services programs? And then it says, are they adequately trained to collect data? I don't know who they is in that question.
Okay, so if a person is not in a day program, then the service coordinators, first of all, were required to have meetings with the teams to discuss whether or not the person was planning to return to the day program. If they're not planning to return to the day program, then that service is removed from the ISP. So therefore, there wouldn't be anything to observe or request from the day program provider because they're not actively providing day services for the person. So the ISP wouldn't be something they would be monitoring because that service and all the goals and objectives and outcomes that were tied to day services would have been discontinued in the ISP.
Thank you.
You're welcome.
Kirk, can you make Winslow a panelist? I'm not sure why he's not, but somehow he dropped from being a panelist. And someone just mentioned that he has his hand up.
I'm sorry, I didn't get the name of who you said to make a panelist.
Winslow. For whatever
He is
reason,
panelist.
he's unable to speak, but when I look at the panelist list, he's not there anymore. So somehow he dropped off our list. That's what
He's
happens.
here. His video is on. Winslow, can you hear us?
Of course I can hear you. No, I was just going to respond to the question, but Shasta adequately answered it. And, you know, once again, I'm so proud of my team for being able to kind of be there. I'm on leave for a couple of days, but she answered the question the way I would. So.
There's a question. Is there new guidance on PPE for healthcare facilities since May 19, 2021? I think we spoke last week that there was new guidance posted for ICFs and people should take a look at it. But Nelson, you could speak to this.
I think she's referring to the PPE guidance for healthcare providers, and that there are some minor updates that are in progress in the final approval process for that document, but nothing has been posted since that May 19th document that she's referring to, so that is correct.
Okay, well, it is 1 o'clock. Thank you, everyone, and we will talk again next week.